ultra high yield top tips review. It's not a comprehensive review. I've tried to put asterisks by the salient points that I think are highly testable in the exam. Took a lot of the data from many of the review sources, including the recent Miller Review book, but also a lot of the journals. We're going to go fast to try and keep up, but we'll try and give you the high yield top tips. So starting off with distal radius fractures. Many of you treat distal radius fractures and your eyes are drawn to the radiocarpal joint, but don't forget the sigmoid notch. That's very important regarding the DRUJ. Its stability of the carpus is primarily maintained by intrinsic and extrinsic ligaments. And remember, with the distal radius fractures, such as this seen here, you can see where the fracture is coming through the radial styloid. Look where the force is going. And so the primary intrinsic ligament that's injured is the scapholunate ligament. You have to read the question carefully, however, as the most common intra-articular soft tissue injury is the TFCC and not the scapholunate ligament. And regarding TFCC, we'll touch on this in a little bit later, but essentially you treat this non-operatively unless the DRUJ is unstable. The key thing here is to remember the normal parameters. Remember the rule of 11. Ideally, you want to have 11 millimeters of radial height so you don't get ulnar impaction, 22 degrees of radial inclination, and 11 degrees of volar tilt. In terms of non-operative treatment, essentially it's for non-displaced or fractures which are okay aligned. The key thing here is that you want to watch these patients as approximately 3 to 4 months post-treatment, they're at risk of tendon rupture, and the primary tendon that can rupture is the EPL. And in terms of the treatment for this, it's not primary repair as the tendon edges aren't very good quality. It's a tendon transfer of the EIP to the EPL. When you're trying to maintain the fracture alignment, there's numerous parameters that are indicated in terms of its importance, but remember that age is the primary determinant to maintain fracture alignment. Really, you want to have age less than 60 years of age. Recently, Tornetta published the importance of maintaining the hooking the volar cortex to prevent dorsal instability, but remember that age is the primary determinant. In general, when you're looking at the management of patients over the age of 65, be that operative or non-operative, patients that have had surgery, it's not surprising. X-rays look better, but they also have improved grip strength. But otherwise, there's really no difference in terms of functional outcomes. Now, when should you operate? Well, the Academy has published numerous guidelines, but the three most important are that the articular surface should be as close as possible, no more than 2 millimeters of intra-articular displacement. You should have no more than post-reduction radial shortening of more than 3 millimeters, because remember, we worry about ulnar impaction, and the dorsal tilt should not be more than 10 degrees off neutral. There are a myriad of different treatment methods if you are going to operate on them, ranging from dorsal plating to volar plating, and each of them have their nuances in terms of complications. If you go dorsal, one of the issues here is obviously extensor tendon issues, and the primary tendon that you worry about is the EPL. If you go volar, the main tendons that you worry about are the FPL and the FDP of the index finger. But don't forget, if the screws are long, the extensor tendons, for example, the EPL is also at risk. If you see an example of an external fixator, look at the position of the carpus. As this is overly distracted, you'll get CRPS and poor digital motion. In addition, if patients either get carpal tunnel, be that acutely or at delayed presentation, the answer here is to release the carpal tunnel. Patients still do make functional gains. There's been a lot of debate about the role of vitamin C in preventing CRPS. However, there's still level 1 evidence showing that vitamin C given for 50 days in patients with normal renal function at a dose of 500 milligrams reduces the incidence of CRPS. But there's some controversy about that, so they may not ask you that question. Now, moving on to the ulnar side of the wrist. The key thing here is to remember is that the ulnar is a fixed unit of the forearm. And so when you rotate in pronosupination, remember that the radius and the carpus and the hand rotate around the ulnar. In terms of the stability, 20% is given by bony stability. So remember that it's really the soft tissues that are the most important for stability of the DRUJ. I highlighted here a couple of ligaments that are important, especially in distal radius fractures. You have the distal oblique bundle, and also the radial ulnar ligaments. And remember, it's the deep foveal insertion that is critical for DRUJ stability, not the ulnar styloid. This was an evidence-based article looking at a patient with an extra-articular distal radius fracture, and they asked how should one manage this if they have an ulnar styloid fracture. Essentially, what one needs to do is reduce and fix the distal radius and then examine the DRUJ. If it's stable, you can then treat it non-operatively. However, if it's unstable after fixing the distal radius, that's when you need to address this. Moving on now to carpal fractures and instability. Obviously, the most important here is the scaphoid fracture. And what I've highlighted here is that the mechanism of injury. It tends to be in wrist extension and radial deviation. And I delineate that point as when the wrist is in ulnar deviation, that's when you get more intercarpal ligament injuries, such as a scapholunate ligament. In adults, the majority of these fractures occur in the waist, but remember, in the pediatric population, the distal third or tuberosity fractures are most common. In terms of radiographs, they can be negative in 30% of cases. And so look at the question carefully and look at what type of imaging analysis that they're asking for. If they're looking at what's the best sensitivity and specificity for picking up an occult scaphoid fracture, the answer is an MRI. It used to be a bone scan, but now the answer is an MRI. And when you're looking at a CT scan, that's essentially looking for displacement or instability of the fracture and potentially whether to treat this non-operatively or operatively. So moving on into terms of treatment, for stable acute fractures, there's really no difference in terms of the type of cast you use. Study back by Gelman showed that long arm casting did better than short arm casting, but now there's really no difference. Many studies have come out showing that it doesn't matter in the position of the thumb either. If you are going to treat these non-operatively for stable acute fractures, mind you, the union rate is very good, but it does determine in terms of the length based where the fracture is. You can see for distal pole fractures, they heal well because the blood supply is a retrograde blood supply coming from distal to proximal. But you can see for proximal fractures, it can take up to 5 to 6 months. And so that's relatively an operative indication. In addition, you want to look for instability. So if, in general, rule of thumb, if you can see the x-ray and shows a fracture, it tends to mean at least a millimeter of displacement, and that tends to be an operative indication. But don't forget those patients, for example, with a lot of trauma, such as a greater arc perilunate fracture dislocation, demonstrating that there's significant injury and force of mechanism, and these need to be fixed. In general, comparing operative versus non-operative for a non-displaced fracture, there's no difference in terms of union rate. So that's important to remember, but there is a quicker return to work and better grip strength if you fix them compared to non-operative treatment. But don't forget, in those patients who have operative fixation, it's not surprising they have a higher complication rate. Where should you place the screw? Essentially, the answer here is down the longitudinal axis of the scaphoid. The longer the screw, the wider the screw. Anything up to about 3 to 3.5 millimeters is the answer here, because essentially you get better biomechanical rigidity of the construct. So which approach should you use? Should you go volar or should you go dorsal? Each of them have their advantages and disadvantages. Essentially, you go volar if it's a distal fracture. The key thing here is that you're maintaining the primary blood supply to the scaphoid, which comes through the dorsal ridge vessels. It allows, if you think of the scaphoid, it looks like a cashew nut. And so when the cashew nut breaks and you want to correct its alignment, if you go volar, you can reduce that so-called humpback deformity, and it allows you to place the screw. It's, however, harder to place the screw in the central axis from a volar approach, so you really need to do something with the trapezium. In terms of a dorsal approach, it's primarily for proximal pole fractures, and this tends to promote the best placement of the screw down the central axis. In addition, it allows you to do some form of vascularized bone grafting if you're going from the dorsal approach, and the most common blood supply used for vascularized bone grafting from the dorsal side is the 1-2 ICSRA. You can also use percutaneous or arthroscopic as shown in this diagram, and this is primarily for non-displaced fractures. This is a key slide looking at the blood supply of the scaphoid, and remember that the majority of the blood supply comes from a retrograde manner from the dorsal ridge vessels, but you can see that relative watershed area, and that's why displacement is poorly tolerated for scaphoid fractures. Well, what about non-unions? How should you treat this? This is purely based on if there's arthritis or not. If there's arthritis, you want to move away from saving the scaphoid to a salvage procedure. You also want to assess vascularity, and despite the myriad of different tests here, the key is intraoperative vascularity of the proximal pole. That is a primary way to determine and the best way to determine vascularity of the proximal pole. Just some general guidelines in terms of scaphoid fractures and non-unions. If there's no AVN, so there's good blood supply to the scaphoid, and the scaphoid is well aligned, you can fix this, be this dorsal or volar approach. If there's good blood supply, so no AVN, but you've got that humpback deformity, remember we talked about the cashew nut principle. Here you need to go palmar and reduce the malalignment and possibly put a bone graft. And I've put in italics and iliac crest. It doesn't have to be iliac crest. The principle is to go volar for a humpback deformity. If there's no blood supply and you have humpback deformity, well, here you'll need to fix this and give a vascularized bone graft. I put in italics the 1-2 ICSRA. You can also do palmar distal radius grafts, but that tends to be the main one used. And finally, if there's AVN and humpback deformity, You need to correct the humpback, so you need to go volar, and then you need to give some kind of vascularized structural grasp, for example, the medial femoral condyle. Now, moving on to carpal instability. This can be confusing, but essentially there's four main types of carpal instability. There's carpal instability non-dissociative, where you have instability between the distal radius and the proximal carpal row, for example, seen on the X-ray on the right with that large radial styloid fragment. You can have mid-carpal instability, where you have instability between the proximal and distal carpal rows, as seen on the left side. This is probably what they'll test you on in the carpal instability dissociative, where you have instability within a row, for example, within the proximal carpal row. It could be a scapholunate or lunar triquetral ligament, and we'll go on to that in a second. You can have a carpal instability adaptive. So, for example, if you look at this patient with a distal radius fracture, if you draw a line down the longitudinal axis of the radius, you can see that there's dorsal pointing of the lunate, called DZ, and there's flexion of the capitate, giving some called mid-carpal instability. And so this was treated by operative fixation, and you can see how the carpus is now well aligned. And finally, you have carpal instability complex, for example, a perilunate injury. The key thing here is to carefully look at the x-rays in the test and look at Galua's lines and see if the carpus is well aligned, because up to 25% of these cases are missed. And if they show a perilunate injury for the test, essentially the answer is early open reduction internal fixation. There's some controversy, should you go dorsal or volar or both? Most people go dorsal, so that would be the answer if offered. The reason why the scapholunate ligament is important is given by this diagram. You can see when you make a composite fist, 80% of the load is transferred from the distal carpal row through the proximal carpal row through this small ligament. And this really explains what happens to the kinematics of the wrist. So if you look at this cross-sectional area, you'll see that the scaphoid has a natural tendency to want to flex because look at the distal push of the trapezium along the radiuscaphocapitate ligament. Now, the triquetrum wants to extend, and this is because of the push from the hamate. And so really the lunate is an interconnected segment between the scaphoid and the triquetrum. So now if you look at this cartoon, when the scapholunate ligament is injured, well, the lunate is attached to the triquetrum, and we know that the triquetrum wants to extend, and as a result of this, the lunate will extend, giving you this dorsal intercalated segment instability. And the only thing you need to remember here is dorsal is because the lunate is pointing in a dorsal manner. So with scapholunate ligament injury, you can see you have this extension of the lunate pointing dorsal, and the key thing here is this is left untreated, they tend to go into arthrosis. The converse is lunar triquetral ligament injury. So remember, when the lunar triquetral ligament is injured, the lunate is now attached to the scaphoid, and the scaphoid wants to flex. So the lunate wants to flex down, pointing volar, giving you this VZ deformity. In terms of metacarpal and phalangeal injuries, the key thing here is to remember that most of these are treated non-operatively, but there are some operative indications, primarily if it's an open fracture or if there's malrotation. There's three main forms of fixation. Pinning is the least stable, but gives you the least scarring, whereas open reduction internal fixation, if they show you an x-ray of this, the biggest issue here is that you worry about extensor tendon dysfunction and scarring, and so you need to get these patients moving early. I think this is readily testable information, and that's the dorsal PIP joint fracture dislocation. There's been a lot of work in this, and if you look here at the bottom left-hand corner, you can see when the fracture is less than 30% of the base of the middle phalanx, these fractures tend to be stable. But when it's anywhere greater than 30%, usually more than 40%, you tend to get instability. And the key thing here is to look at the lateral radiograph for this V sign, which means that when the patients are moving their joint, what they're doing is that they're rather hinging at the fracture site as opposed to rotating along the central axis. So in terms of treatment, ideally you want to get the joint moving early. For type 1s and type 2s, you can put a dorsal extension splint, which keeps the PIP joint reduced and patients move, or this dynamic external fixator, which gives you traction at the PIP joint and also promotes early motion. For type 3, remember that's when it's greater than 50%. These fractures are unstable. So if they show you, for example, a CT scan with a large single fragment, this is amenable to open reduction internal fixation. But they may ask you about the hemihamate, and essentially this is taking a piece of the hamate, flipping it around to restore the volar buttress of the middle phalanx to prevent dorsal subluxation. So this is fair game, I think. And for the chronic injury, the hemihamate is the answer, as long as there's no arthrosis. If the joint is arthritic, the answer is either arthrodesis or arthroplasty, and we'll touch base that in a minute. Moving on to the thumb, the CMC joint. The key thing here is to remember there's minimal osteostability. It's primarily soft tissue related. And when you pinch between the thumb and the index finger, the force between the thumb and the index finger is magnified 12-fold at the CMC joint. We talked about the soft tissue stabilizers. In terms of static stabilizers, there are 16 ligaments. Thankfully, you don't need to know all of them. There's two most important ones you do. You have the volar or oblique ligament, and this is essentially important in terms of a Bennett fracture, and we'll touch about that in a minute. But the primary restraint to dorsal subluxation of the CMC joint is the dorsal radial ligament. So in terms of fractures and fracture dislocation, this is the epibasal fracture, which is an extra-articular fracture of the thumb metacarpal. You can see that it has apex dorsal angulation, and you can accept up to 30 degrees of angulation because of the excellent motion at the CMC joint. Any greater than this, then you worry about MCP joint hyperextension. My mnemonic in terms of treatment and reduction here is tape. You want to put traction, abduction, pronation, and an extension, and that reduces the thumb metacarpal to the fracture fragment for which you can then fix. This is the Bennett fracture, and we touched about the volar oblique ligament earlier. The key thing here is to remember that the fragment attached to the volar oblique ligament is the reduced fracture fragment, and so what's displaced is the dorsal radial translation of the thumb metacarpal. The key thing here is that these are amenable to closed reduction percutaneous pinning. That tends to be the main answer. But if it's comminuted or the reduction is off, then you make an incision between the glabrous and non-glabrous skin of the thumb. And the key structures here to remember are the dorsal radial branch, also the lateral antebrachial cutaneous nerve, which are at risk. Moving on now to the thumb MCP joint. Remember that the thumb MCP joint is like a box. And essentially you have the dorsal capsule, the palmar capsule, and you have the radial and ulnar collateral ligaments. You also have dynamic stabilizers, primarily muscular. There's many around the MCP joint. The key one here is to remember that the adductor pollicis is the primary dynamic stabilizer of the thumb MCP joint. In terms of the ulnar collateral ligament, it's divided into true and accessory. When you injure this in an acute manner, this is called skier's thumb, and this is the most common injury of the thumb MCP joint. And the key thing here is to remember what happens to the proximal phalanx, and the mnemonic here is PRS. Remember that the proximal phalanx rotates and supinates around the intact radiocollateral ligament, and that may be asked on the test. If it's chronically disrupted, this is the gamekeeper's thumb. The majority of disruptions of the ulnar collateral ligament occur distally, and the reason for this is that the ligament tapers distally and it's weaker distally, and that's why the majority of ruptures occur distally, as opposed to the radiocollateral ligament, where most occur proximally. So in terms of treatment, there's three main types of stability of the ulnar collateral ligament. Stage 1 is when it's injured, but there's a good endpoint. Stage 2 is when it's injured, but there is a slight increase in laxity, but again, a good endpoint. And stage 3, where there's no endpoint. And this leads on to treatment. So for example, for stages 1 and stage 2, these can be treated non-operatively. But stage 3, this is where there's an incomplete tear. These will need to be fixed. You can also have a stena lesion where you have so much radial deformity of the MCP joint that essentially what happens is that the adductor aponeurosis interposes underneath the ulnar collateral ligament and essentially acts as a mechanical barrier preventing its attachment. So this is an obvious operative indication, as well as large displaced fractures. Now, on the other side, you have the radiocollateral ligament. And remember, we talked about what happens when the ulnar collateral ligament, but remember when the radiocollateral ligament is injured, the proximal phalanx pronates around the intact ulnar collateral ligament. It's wider distally than proximally. So on the radial side, you get more tears proximally. Remember, on the ulnar collateral ligament, more tears occur distally. And it has a true version, which essentially runs in an oblique manner from the metacarpal condyle to the proximal phalanx on the volar side, which is toward inflection, and the accessory one, which is essentially toward an extension. And in terms of the treatment algorithm, this is similar to the ulnar collateral ligament. Now, moving on to tendon injuries, the extensor and flexor tendons have essentially zones. And the easy way to remember the extensor zones are the joints. Remember, odd is for the joints. So for example, the DIP, PIP, and MCP joint, it's zone 1, 3, and 5, and then the evens are in between that. The reason why this is important is because each zone has a characteristic injury. So for example, a zone 1 is a mallet deformity. And essentially here, this is where you get disruption of the terminal tendon at the DIP joint. Elderly patients are also prone to DIP joint mallet deformity because there's a relative avascular zone, and this could be injured with the osteophytes. In terms of treatment options, The board answer really is non-operative treatment, keeping the DIP joint in extension for about 6 weeks. There are some operative indications, but these are rare, so you really have to look at the question. So for example, if they show you an x-ray where there's volar subluxation of the DIP joint, that's an operative indication. But the main operative indication is this, and this is a Salter-Harris fracture of the distal phalanx called a Seymour fracture. And essentially, this is an open injury which needs to go to the operating room where you extricate the nail bed that's interposed in the fracture fragment, because if not, these patients are at risk of infection, and so this shouldn't be missed. So this is one of the key operative indications for distal phalanx injuries. Now, in terms of central slip injuries, this is zone 3. Remember the zones 1, 3, and 5. So the key thing here, the reason why you need to address this is because of the fear of the boutonniere deformity. Now remember that the central slip extends the middle phalanx, and so if this is disrupted, and also there's attenuation of the triangular ligament that sits on the proximal dorsal aspect of the middle phalanx, then the conjoined lateral bands migrate palmar, giving you hyperflexion of the PIP joint and hyperextension of the DIP joint. So that's why you want to recognize this injury. The majority of these injuries can be treated non-operatively. For example, if it's a closed injury, you want to encourage the PIP joint to be splintered in extension and allow active DIP joint motion so the lateral bands migrate dorsal, giving you improved extensor force at the PIP joint. But the operative indications is essentially if it's an open fracture or if you have a large displaced avulsion fracture which contains a central slip. So zone 5 is the MCP joint injury. The key thing here is the fight bite. And this is essentially an open injury until proven otherwise. So these need to go to the operating room to be irrigated in debridement. The most common bacteria is Staphylococcus aureus, but in the test, they also may show you other characteristic organisms, and Eikenella is the answer here. And these need to be operatively debrided and patients put on antibiotics. And finally, the other key extensor tendon type of injury is the sagittal band injury. Now, the sagittal band runs from the volar plate to the central tendon, and it allows the central tendon to groove along the longitudinal axis of the MCP joint. And if this is injured, the central tendon can move to either side. And so these patients have difficulty initiating extension of the MCP joint. But if they show you in the test that the patient can maintain active extension once the MCP joint is reduced from a flexed to an extended position, the answer here is that there's a sagittal band injury. And if it's picked up acutely, you can treat these non-operatively. If it's chronic, they can either be repaired or have a reconstruction. So moving on to the flexor side of the hand, and remember we talked about the zones in the hand. The key thing here is zone 2. This used to be called, or still is called, no man's land, and runs from the A1 pulley to the FDS insertion. And the biggest issue here is that the tendon here is intrasynovial in location and is very prone to scarring. And that's the biggest issue with flexor tendon repair in this area. If it's a partial injury, so less than 60%, the answer here is that these don't need to be repaired. You want to do early range of motion. And the biggest complication here is triggering, because remember that the frayed tendon can catch on the pulley, causing triggering. If you're going to repair them, these are the key points. You want to have as many strands as you can across the repair site. The minimum is 4 strands, as this will prevent, ideally, rupture. You want to try and perform a circumferential epitendinous stitch, as this will increase the strength of your repair. And you want to avoid gap formation. Gap formation has been a curse for re-rupture. In terms of the digits, the key pulleys here to remember are the A2 and the A4. And in the thumb, the key pulley here is the oblique pulley. And you want to get patients moving early because this will decrease adhesions and also improve excursion of your repair. Now moving on to trigger finger. This is essentially when the patient comes in and the finger is stuck in this position because the flexor tendon is caught on the A1 pulley. But in terms of testable items here, remember that up to 60% of patients will also have carpal tunnel syndrome at the same time. And so you need to address this at the same time as the pulley. Steroids work great, but they're less effective in certain patients. For example, if they're diabetic, it raises the blood sugars. If they have chronic symptoms and multiple digits involved, steroid injections are less efficacious. And if you're going to operate on them, essentially the answer is releasing the A1 pulley. But if they give you a question, for example, where there's a chronic PIP joint flexion contracture, in addition to assessing and treating the A1 pulley, you can also excise the ulnar FDS tendon. Overzealous release can cause bowstringing, which is when you release the A2 pulley, and inadequate release is where these patients still have symptoms. De Quervain's tenosynovitis is essentially inflammation of the first dorsal compartment. Remember, there's two key tendons in this compartment, namely the EPB and the abductor pollicis longus. And the primary differential diagnosis is basilar thumb joint arthritis. Steroid injections work well. There's really no benefit of one splint over another. And if you are going to operate them, in terms of risk factors, you want to ensure that dorsal sensory branch of the radial nerve is protected. There's multiple slips of the APL that also need to be released. And remember that the EPB can be in its own compartment. So if they give you a question of why a patient may fail, well, it could be that the EPB was not released. In terms of the TFCC and the DRUJ, in terms of the TFCC, there's two types of classification. There's the acute classification, which is type 1, and type 2, which is the chronic classification, for example, in ulnar impaction. I put this picture up here of the meniscus just to remind you that, like the meniscus, the peripheral of the TFCC is vascularized. So see, these are amenable to repair. The central area are avascular and not amenable to repair. So in terms of a 1A tear, this is where you have a central defect. These aren't amenable to repair because there's poor blood supply, so you debride these. A 1B and a 1C are an ulnar or volar tear. Because they're peripheral, they have good blood supply, so these can be fixed. And there's really no difference between arthroscopic versus open repair, so I doubt that they'll ask you that. And a 1D tear is often associated with a distal radius fracture, and these should be fixed as these can lead to instability. And remember, because it's peripheral, they can be repaired because they have good blood supply. Ulnar impaction simply means that the ulnar is longer than the radius, and when one pronates, effectively the ulnar becomes longer than the radius and can irritate the TFCC and the ulnar carpal structures. The main area here in terms of diagnosis is patients have pain with wrist extension and ulnar deviation because the ulnar is hitting the carpus. You want to get a true PA radiograph here because when you have pronation, remember that the ulnar is effectively lengthened, and in supination, the ulnar is effectively shortened. So you want to get a true PA radiograph. And this is what an MRI scan may look like, or an X-ray similarly. They'll show you abutment of the ulnar on the ulnar aspect of the lunate. And the key differential here is Kienbock's disease. And you can see in this MRI, you have diffuse lunate edema. In terms of treatment, most ulnar-sided pain should be initially treated non-operatively unless there's frank instability. But if these fail, you can either shorten the ulnar doing a wafer procedure where you take the distal end of the ulnar off, or you do an ulnar shortening osteotomy. So in the test, for example, if they say that the patient has lunar triquetral instability and there's no arthritis of the DRUJ, the answer is ulnar shortening osteotomy, as that also stabilizes the lunar triquetral joint. In terms of DRUJ arthritis, patients complain of pain and also limitation with pronosupination. Again, treatment options, you want to maximize non-operative treatment, and then are a myriad of different operative indications. If these patients are low demand, these are types of treatments that are used. For example, a rheumatoid arthritis patient. You can do a Dara procedure where you excise the distal ulnar. You can do a HIT procedure, or a hemiresection interposition arthroplasty, where you excise a little bit of the distal ulnar and you put this tendon into position. Or you can do a Solvay-Capangine. And essentially here what you're doing is excising the distal ulnar and fusing it to the distal radius. The biggest problem with these procedures, however, is that the proximal ulnar becomes unstable. So when patients pronosupinate, they can have clicking and pain. So remember, if possible, you always want to try and maintain the distal ulnar. What are the other options? Well, you can replace the distal ulnar, but the biggest complication here is instability. So these patients need to have good soft tissue envelopes. So probably not a good option in rheumatoid arthritis, better in osteoarthritis. You can do a linked prosthesis. The biggest issue here is, like a total elbow, these patients have lifelong lifting restrictions. So this is not a good option in a manual laborer. And if these patients present with this type of picture, you can interpose the Achilles tendon, which essentially acts as a cushion between the radius and the ulnar. This is a common area of questioning, namely the subungual hematoma. And what should you do here? Well, essentially, remember that there's injury to the vascular bed. And if the hematoma is less than 50%, the answer here is trephination. But it's greater than 50%, that means that there's more injury to the nail bed, so you want to remove the nail and do a nail bed repair. But the complications here are primarily if you over-tighten them, you can have a hook nail deformity or a nail ridge. And remember, up to about a year, these patients have cold intolerance or tip sensitivity. And that tends to be the question that is most commonly asked. Well, what about if you injure the tip of the finger? There's lots of areas where the tissue loss occurs. If there's no exposed bone and the defect is lesser than a centimeter, treat these non-operatively with dressing changes. These patients do just fine. But if you're going to do a skin graft, the answer is full thickness skin grafts because this is more durable than a split thickness skin graft, and we'll get into that in a second. Now, if you've lost volar tissue, so you have a volar oblique injury, it's very hard to mobilize tissue right at that site to cover it. And so you can do a cross finger flap here. And essentially, this is where you're putting the finger adjacent to the other digit. And you can see that skin is flipped around. But look at the PIP joint. It's flexed for about 3 weeks. So the biggest complication here is PIP joint stiffness. You can also do a thenar flap where you place the finger onto the base of the thumb. But again, PIP joint stiffness is common. You can take tissue from the same finger and move it distally. That's a homodigital flap. Hetero meaning from a different digit. And if you use palmar skin on the thumb, the answer tends to be a Moberg advancement flap, where you take skin from the palmar aspect of the thumb and swing it distally. And this can be done because the blood supply is independent of the dorsal side. Now, what about if you have this shaving injury where you've got a dorsal oblique injury? Well, here you have plenty of tissue palmarly, so you can do a V to Y advancement flap where you can extend the tissue and cover the defect, or you can do it from a lateral side. Or you can shorten the bone and swing the palmar skin to cover the defect. Soft tissue coverage. The key thing here for the test is remember the reconstructive ladder. You want to start simple and be more complicated if needed. So for the test, choose the simplest type of technique to achieve coverage. In terms of skin grafting, the 3 key words here are how the skin graft takes. Initially takes by imbibition, then inosculation, and then finally undergoes a revascularization procedure. And if these patients fail early, it's either from shear stress or hematoma. Split thickness skin graft is used essentially for dorsal hand coverage. And the reason for this is because the skin contracts more and is less durable. And so if you're going to cover the palmar side, which needs more sensitive skin and is more durable, you need a full thickness skin graft. Well, what about a flap? Now, remember the definition of a flap is essentially when the tissue has its blood supply, and it's really needed when a skin graft won't take, and that's essentially when you have exposed bone or tendon which doesn't have its own paratenon or epitenon or exposed hardware. So you can do a local flap, for example, a pedicle flap. So you can take skin, for example, from the first dorsal index finger and expose it and rotate this around to the thumb. Or you can do a radial forearm flap. And the key thing here is to do an Allen's test, as you're sacrificing essentially the radial artery. And so if the ulnar artery is not perfusing the hand, this is contraindicated. In terms of the test, if the defect is distal, so in the dorsal of the hand, you want to essentially do a distally based radial forearm flap. If the defect is at the elbow, it needs to be a proximally based radial forearm flap to reach the defect. You can also do a cross finger flap, and we discussed this earlier. This is dependent on its microcirculation. If they show you a patient, for example, that's lost tissue over the thumb, you want to maintain length. You don't want to shorten the thumb because later on you may do a toe to hand transfer. So the answer here is, for example, an abdomen or groin flap. And free flaps, I think, are fair game. And the reason for this is that they can test you on the named blood supply. So I've listed the 4 most common types here. Here you want to really remember the blood supply to each muscle. Replantation is also a good question to ask because of the indications. And so we just run through them. Essentially, if the thumb is injured, you want to try and maintain the thumb at all costs if possible. If the injury is distal to zone 1, remember zone 2 was a no man's land where you get a lot of scarring, but if it's distal to that, these patients can do better. So you want to try and replant that. And also in a child, you want to try and replant a child. Remember the warm and cold ischemia times, as these have an important role in terms of when or when not to replant. And this leads into the contraindication. So for example, if the ischemia time is prolonged, it's a contraindication. And if it's a severe crush injury or a traction injury or a zone 2, or if the patient is too sick to undergo a replant, these are the main contraindications. In terms of when you do a replant, when will these fail? Well, if they fail acutely, the problem here is a lack of inflow, so that you've got a clot in the artery and you can get a spasm here. Greater than 12 hours, and this is probably what they'll ask, is where the outflow is affected, so you get venous congestion. And the reason why they'll ask you is that these patients can be treated with leeches because they have a natural anticoagulant called hirudin. The testable issues here are also the bacteria that they excrete, Aeromonas, and so these patients need to be put on some form of prophylaxis, namely either ceftriaxone or ciprofloxacin. After 1 week, the biggest risk is infection. And the most common secondary procedure performed after a replant, assuming it survived, is that the tendons scar down. Remember, we talked about zone 2? That's where they get a tendon adhesion. You need to do a tenolysis. Neuropathy, a fair game. And the reason why is because their symptoms can vary. So carpal tunnel is the most common neuropathy we see. In adults, we don't really know the cause, so the answer here is idiopathic, but kids, it's mucopolysaccharidosis. These patients can present with paresthesias from the thumb to the radial border of the ring finger. The most sensitive and specific test is the carpal compression or Durkin's test, where you press on the carpal tunnel. And if they show you a question of thenar atrophy, that's a late finding. So that what they may be going on here is some form of tendon transfer, doing an opponent's plasty, because patients have difficulty getting the thumb across into their palm. And we'll go over this in a second. I put this here because they may put certain buzzwords. So for example, on the EMG, if they talk about sharp waves or fibrillations, that tends to tell you that there's more denervation going on. And you need to know the latencies of sensory latency are greater than 3.5 milliseconds and motor latency greater than 4.5 milliseconds, because they may not give you normal values. And if it's over this, that tends to tell you that the median nerve is being compressed. Treatment options, splint and steroid injections work very well, especially in the short term, so you want to try non-operative treatment. If they push you towards operative indications, essentially there's no difference between open or endoscopic release. There's a higher risk of nerve injury at endoscopic, purported quicker return to work with endoscopic, but a higher risk of nerve injury. So that's the basic differential between the two. This is fair game in terms of what's the most common cause of the recurrent motor branch, and essentially just distal to the transverse carpal ligament. In most patients, in over 50%, you get a motor branch coming off distally to the transverse carpal ligament, innervating the abductors and the thenar muscles, and that's the extraligamentous course. Pronator syndrome can differentiate from carpal tunnel because these patients have compression of the median nerve more proximally. So not only do they complain of paresthesias in the hand, but they can also have some forearm pain. But remember, the differential here is that these patients will have decreased sensation over the thenar region because the palmocutaneous branch of the median nerve is affected. They may show you an X-ray here where you can see a supracondylar process, and these patients will have a ligament of Struthers. And so essentially the treatment here is to release all these points of constriction for the purposes of the test. Cubital tunnel syndrome, essentially here the ulnar nerve is being compressed at the medial epicondyle region. Patients complain of medial forearm pain and paresthesias in the small finger and the ulnar aspect of the ring finger. And this is my mnemonic here, AOA team and FCU. There's many compression points. A is for arcade of Struthers. O is Osborne's ligament. T is for the medial head of the triceps. AE is the epitrochlearis anconeus. M is for the medial intermuscular septum, and also don't forget the FCU. Many signs and symptoms. I've tried to water down the most important one. The Warneberg sign is essentially when you ask the patients to bring their fingers together, they can't bring the small finger in. It remains in an abducted position. And this is because they lose the interosseous function, but they still have maintenance of the extensor digiti minimi. They can also have a Froment sign. So when you ask them to pinch down, they lose adduction, so they flex at the IP joint. And you also can get clawing. Now, clawing can be a little bit complicated to understand. Remember that the intrinsics essentially give you this position. This is the intrinsic plus. It's flexion of the MCP joint and extension of the IP joint. And so when you get an ulnar intrinsic minus, it means you get hyperextension of the MCP joint and flexion of the DIP joint, giving you clawing. Ironically, when the injury is higher up, the FTP is out of function. And so because you lack the flexors, remember you can't do this, so patients have less clawing. And so they tend to present like this. If it's more of a proximally based ulnar constriction, if it's distal, the FTP is intact, and so they'll give you more clawing. In terms of electrodiagnostic tests, the key differential here is to remember 50 milliseconds of conduction. If it's less than this, that tends to tell you that the ulnar nerve is being impinged. If you are going to treat these, if the nerve is stable, the answer is in situ decompression. However, if the nerve is unstable, that's when you're doing some form of transposition. And I don't think they'll get into subcutaneous or submuscular because there's controversy about this. In terms of peripheral nerve injuries, before we talk about those, I think it's important for you to remember that the axon is the projection of the nerve cell, i.e. the neuron, carrying the impulses to the target. And there's essentially three main types from the Seddon classification. The best type to get is the neuropraxia. Essentially, this is where there's a conduction block along the axon, but the three membranes along the nerve, namely the epineurium, the perineurium, and the endoneurium, remain intact. So that's the best prognosis. Axontomesis, here is when the axon is injured, and so at the site of injury, distally, you get Wallerian degeneration, but you do get some form of axonal regeneration, and this can take a while to occur, so the prognosis here is not as good as a neuropraxia. And the worst is a neuroptomesis, and essentially this is where all layers, namely the epineurium, the endoneurium, and the perineurium, are injured, and so recovery here is very poor. Remember, of all the different types of modalities for the best prognosis for recovery, it's age. The younger you are, the better you do. When you're repairing nerves, ideally, you want to have a direct coaptation of the nerve endings in a tension-free manner. But sometimes you can't do this and there's a defect. So what should you do? Ideally, you want to use a nerve autograft, but for sensory recovery, there's essentially really no difference between nerve autograft or a synthetic conduit, but that's for sensory. For motor, the gold standard is still using nerve autograft. Brachial plexus. So this is a massive topic to do, and it's very difficult to do it in a short period of time. I think the key thing, unfortunately, is that you have to draw out the brachial plexus in the test. And remember the roots, the trunks, division, the cords, and the branches. Once you draw this out, it's easy to try and work out the answers. Remember, in terms of the proximal branches from the root level, there's essentially three. And the reason why these are important is that they have not only muscle, but also diaphragm innervation. The branches from the trunk, the main branch here is the suprascapular nerve, giving you supra to infraspinatus innervation. In terms of the branches from the cord level, now these pertain to their relationship to the axillary artery. So you have the medial cord giving you the medial pectoral and medial antebrachial cutaneous, the lateral giving you the lateral pectoral, and the posterior, which innervates the latissimus dorsi and the subscapularis. And then eventually you have the terminal cord branches. And the terminal branches are essentially the medial terminal cord gives you the ulnar nerve. The lateral terminal cord branch gives you the musculocutaneous nerve. The posterior gives you what I call parts. So posterior for P, A axillary, R radial, T for thoracodorsal, and S for subscapular. So those are the main divisions. And finally, don't forget the medial and lateral cords will join and innervate and form the median nerve. Main test question is Horner syndrome. This is a preganglionic injury, the worst prognosis because essentially here the brachial plexus comes off the spinal cord and is ripped at that level. And these patients have ptosis, anhidrosis, enophthalmos, and meiosis. Tendon transfers. So if there's a high radial nerve injury, so this is proximal to the elbow, remember what does the radial nerve do? It essentially innervates wrist extension and finger extension. So you lose all of that. But if it's a low radial nerve injury, essentially you do have some innervation here of the ECRL and the ECRB. So you do get weakness of wrist extension, but you lose thumb extension and finger extension. And so the tendon transfer is essentially trying to restore wrist, finger, and thumb extension. These are the three main types that I've listed here. You'll all see that they all use a pronator teres transferred to the ECRB to give you wrist extension. The palmaris longus is transferred to the EPL to give you thumb extension. And then you can either use the FCR for finger extension, the FCU for finger extension, or this transfer where you're using the FDS of the long and ring finger to try and give you better, less synchronized extension of the index and finger, the digits, and the thumb. High median nerve injury means that it's proximal to the AIN. So what does the median nerve innervate? Well, you lose forearm pronation. You have weakness of wrist flexion. Remember, you still have wrist flexion because you have the FCU. You get weakness of finger flexion of the FDP and the FDS of the index and long finger, not the ring and the small finger because that's innervated by the ulnar nerve. But you get weakness of the thumb, especially opposition. Low median nerve injuries, which is essentially distally to the AIN, is carpal tunnel syndrome. And the biggest issue here is that patients have weakness in thumb opposition. They don't lose this because some of them have innervation from the ulnar nerve. Remember, half of the flexor pollicis brevis is innervated by the ulnar nerve. And remember, we talked about tendon transfers, many tendon transfers. I think the easiest ones to remember are the EIP. If the question is worded, what's the easiest rehab? The answer is EIP, where you take the extensor indicis proprius, you bring it around to innervate the thenas. The abductor digiti minimi is essentially used, it's called a Huber transfer, and this is in a pediatric patient where they have basically thumb hyperplasia of the thenas, and so you're taking the abductor digiti minimi and swinging it around. And if they talk about advanced carpal tunnel, essentially you're taking the palmaris longus and doing a transfer for that. So read the question in terms of how they pose that scenario. Ulnar nerve palsy, essentially what's the deficit? And this is what we talked about clawing. Remember, if there's a high nerve palsy, essentially you have weakness of the flexor digitorum profundus of the ring and small finger. So they have clawing where they have hyperextension of the MCP joint, but they don't have as much flexion of the DIP joint, so the fingers are straighter. Whereas if they have a low ulnar nerve palsy, ironically, they have more clawing because the FDPs are still innervated more proximally, so they'll have this position. And if you think about this, these patients have difficulty with grasp. When you try and grab a Coke can, you don't grab it this way. You flex the MCP joints, and so that's what you're trying to restore with your tendon transfers. And you can restore thumb abduction, index finger abduction, or clawing. And the key thing here with clawing is that you're essentially taking your tendon transfer volar to the axis of the MCP joint to take you out of this position to more of a flex position. Moving on now to arthritis. In terms of thumb arthritis, this is the second most common cause of arthritis in the hand. The DIP joint is number 1. The thumb is number 2. There's the Eaton stage classification, stages 1 to stages 4. And the key differential here is between stage 3 and 4. Stages 1 to 3 essentially involve the trapeziometacarpal joint. Stages 4 also involve the STT joint. You have to maximize non-operative treatment. And then what surgical interventions should you do? This is a study in 2012 where patients were randomized to simply removing the trapezium and putting a tendon into position, or removing the trapezium and taking a distally based strip of the FCR, putting it through a drill hole of the metacarpal to suspend this, called the LRTI. And essentially, there was no difference in outcomes. So if they do offer you a test question, essentially the answer will most likely be trapeziectomy is essentially this. There's been no real difference between all the other types of treatment. In terms of PIP joint, the basically differential here is you're trading off stability for motion. So in terms of the border digits, like the index finger, when you're pinching, there's a lot of lateral translatory force, which a joint replacement will probably fail earlier. So the answer here is arthrodesis. The central digits for gripping, you want motion, so you do a joint replacement. Two main joint replacements. You can do a linked joint replacement, i.e. the silicone replacement. This is what it looks like. And essentially, the advantages here, you get excellent pain relief. You don't get increased range of motion. You essentially preserve your range of motion. So whatever you go into the operating room with is what you come out with. The biggest disadvantages are the complications. You can see a very high risk of implant fracture, and as a result of this, you get synovitis. On the converse of linked, you have the unlinked or the unconstrained, and there's two main types. You have the pyrocarbon implant, which is made of this ceramic material. The advantage here is that the modulus of elasticity is similar to cortical bone, so you get less stress shielding. They're very durable and have a very low coefficient of friction. The biggest disadvantage is that there's minimal bony ingrowth and that it can squeak. The converse are these metal surface replacements, and these are like a mini sort of total knee replacement, which use polyethylene. And so the biggest issue here is that you have polyethylene wear. This is a prospective randomized study comparing the three types of implants in patients with osteoarthritis. Essentially, all of the implants did very well, but you can look at the complication rate, much higher in the non-silicone joint replacement. So I think if they ask you on this, the key thing is to remember that silicone has less complications compared to the other types of joint replacement. Rheumatoid arthritis, in the basic science lectures, you heard that rheumatoid arthritis is a systemic disease. Because of this, you get significant synovitis in the pannus, and it essentially eats away at the carpus. And you get intercarpal supination, volar subluxation, and ulnar translocation of the carpus. You can also have something called caput ulnar, and essentially what this means is that the ulnar is more dorsal than the radius, and it essentially eats away at the ulnar-sided tendons, and so patients can complain with loss of extension of the ring and the small finger. You can also have this on the volar side, for example, if you have an osteophyte of the volar scaphoid and it irritates the FPL and then you lose thumb flexion, that's called a Manifelt lesion. I put the bottom about scapholunate widening. If they show you an acute x-ray in a young patient, think scapholunate injury. But if they show you a chronic history of pain and arthritis and there's SL widening, think it can also occur in rheumatoid arthritis or gout. You want to maximize medical treatment. Medical treatment has come a long way, thankfully, but there are surgical indications. If you get patients early, you can do a synovectomy. The characteristic deformity of the wrist you can see here is that you get radial deviation of the wrist, and as a result of this, you get compensatory ulnar drift of the MCP joints. And so if there's no arthritis, you can consider transferring the ECRL, which is a radial deviator of the wrist, to the ECU to realign this. However, if you start getting ulnar translocation, that won't really work. So you need to do something to the carpus. So if the mid-carpal joint is well aligned, you can do a radiolunate fusion. If it's not aligned, then you're thinking of doing a total wrist fusion or total wrist arthroplasty. And remember, for total wrist arthroplasty, you want to have good soft tissue control and good disease control. Dupuytren's disease is essentially contracture of the palmar fascia. The key thing to remember is that the abnormal cell is the myofibroblast. In normal tissue, you have type 1 collagen. In Dupuytren's disease, you have type 3 collagen. In terms of the spiral cord, essentially this is formed from contracture of the palmar fascia of the digit, but the Cleland's ligament is never involved. And so what you do is that the spiral cord displaces the neurovascular bundle to the midline and also more palmar, so it's prone to injury. In terms of treatment, it's essentially functional limitations. If they have contracture of the MCP joint or PIP joint contracture, you can inject it with collagenase, which allows you to essentially dissolve the cord. It does better for the MCP joint than the PIP joint, but patients are at risk of flexor tendon injuries, as is with a needle aponeurotomy, which is using a needle to cut the cord. And if you're going to do surgery, remember that the risks here are CRPS and digital nerve injury. Hand tumors, big topic. We'll fly through the more common ones. Remember a ganglion cyst. The key thing here is to remember the location. Dorsum of the wrist, remember it can be aligned with the scapholunate ligament injury. Volar wrist, it's adjacent to the radial artery, so that's the number one risk factor here for a complication, and also for a risk of patients having radioscaphoid or thumb arthritis. Treatment options, leave alone, you can aspirate them, but if you're going to excise them, remember to get the stalk, as there's a higher recurrence risk. Giant cell tumor of the tendon sheath is the second most common benign soft tissue tumor of the hand. And the treatment here is marginal excision. And why I put this here is because there's a high recurrence rate. And essentially the recurrence is increased if the tumor is coming out of the joint, many skip lesions, or if it's embedded within the tendon, as it makes sense. It's hard to get rid of the tumor from the actual tendon. Schwannoma is the most common benign nerve upper extremity nerve tumor lesion. And the issue here is that as opposed to neurofibromatosis, where you can't excise the tumor from within the nerve, here the lesion grows eccentrically, and so you can essentially shell this tumor out of the nerve, but there is a neurologic complication rate with this procedure. Glomus tumor, I like glomus tumor because of the characteristic history. These patients tend to present with a pinpoint lesion in the fingernail, which is point tender to touch. It gets worse with the cold. And if they inflate a tourniquet, you cut off the blood supply so the pain goes away. Treatment is marginal surgical excision. Because it's marginal, there is a recurrence rate of up to 10%. In terms of the malignant soft tissue tumors, the most common malignancy of the hand, remember how the question is phrased, malignancy of the hand, the most common is squamous cell carcinoma. The best cure rates are with Mohs micrographic surgery by our dermatological colleagues who essentially shave off the tumor to ensure that they get negative margins. But if you are going to operate, it's when the tumor is either poorly differentiated or is much larger than that what can be done with Mohs surgery. Now, the most common soft tissue sarcoma, so this is where I remember how the question is phrased, most common soft tissue sarcoma in the hand is the epithelioid sarcoma. And essentially, their diagnosis can be delayed because initially they present indolently, for example, like a Dupuytren's nodule. They present and migrate along the fascial structures and involve the lymph nodes. So there is a propensity for lymph node involvement. And so treatment is really a wide excision, and you want to try and get negative margins, and that may be an amputation and also chemotherapy. In terms of benign tumors of the bone, the most common benign tumor of the upper extremity is the enchondroma, and most of these present asymptomatically. I put this here because if they reference high mitotic figures, you want to think of the differential here, which is a low-grade chondrosarcoma. And treatment really is curettage, possible bone graft or bone cement. Really no concrete data there. The reason why they like enchondromas is because of syndromes associated with this. So you can get Ollier's disease, where you have multiple enchondromatosis, and they have a malignant transformation rate of up to 30%. It tends to be bony malignancy, as opposed to Maffucci syndrome, where these patients also have hemangiomas, and as a result of this, they can also get soft tissue sarcomas, as well as bony chondro or osteosarcomas. Giant cell tumor of the hand is benign but is locally aggressive. They have propensity for metastases to the lung, which can cause death. They'll show you pathology, remember, characteristic giant cells, and these are an eccentric metadiaphyseal lesion. And so curettage alone has a high local recurrence rate. And so you want to do something more aggressive here. And it's either a wide en bloc resection and a reconstruction, such as a vascularized free fibula. And this is where I tie in, for example, the blood supply to a vascularized free fibula is a perineal artery. And that's how they might tie in the question, or the use of denosumab. Malignant bone tumors, essentially metastatic lung CA is the most common hand malignancy. And remember, the most common location after coming from the lung, it goes to the distal phalanx. The three most common primary bone tumors of the hand, you have to read the question. So if it's an older patient, had a history, for example, of enchondromatosis, you're thinking chondrosarcoma. Remember, these patients need to be treated with surgery as this is chemo-resistant. The converse is osteosarcoma. These patients need adjuvant treatment because if there's a tumor necrosis rate of over 90%, they have improved prognosis. And in a younger patient who may present with more, for example, of an infection, think Ewing sarcoma. And they like this question because of the key translocation of chromosome 11 to 22. So finally now, the elbow. Lateral epicondylitis, we all think of its involvement of the ECRB. Remember, it's a tendinosis, not a true tendinitis. But if patients fail surgical intervention, well, it could be because a lot of these patients also have EDC involvement, and that was not treated. The key pathoanatomy is that it's a non-inflammatory angiofibroblastic tendinosis, not a tendinitis. In terms of treatment, you want to exhaust non-operative treatment. Most patients get better with non-operative treatment. The key buzzword here is the eccentric physical therapy. In terms of operative, open versus arthroscopic, really no difference between the two. Arthroscopic, you may get a faster return to work. Medial epicondylitis involves the pronator teres and the FCR. You want to see if the ulnar nerve is involved, because if the ulnar nerve is involved, that then leads to how you treat these patients. So for example, if you've exhausted non-operative treatment, you debride the medial epicondyle, but if the ulnar nerve is involved, this needs to be released. Distal biceps rupture, remember that the proximal biceps has two heads, as is the distal biceps. And remember, the short head is a better flexor, the long head is a better supinator. Patients lose more supination strength. Remember, not flexor strength, you still have the brachialis, so lose more supination strength. You can do the hook test or get an MRI. And in partial tears, you can treat these non-operatively. These patients lose more supination strength, again, more than flexor strength. And if you're going to fix them, it's essentially the decision. Do you make one or two incisions? And remember, if you make two incisions, there's more dissection, more risk of heterotopic ossification. Single incision, less visualization, higher risk of nerve injury. Elbow arthroscopy, you want to know which side you're on. Medial side, you worry about ulnar nerve irritation or medial antebrachial cutaneous nerve irritation. And on the lateral side, it's the radial nerve or the lateral antebrachial cutaneous nerve. Elbow arthritis, the most common form of elbow arthritis is rheumatoid arthritis. They may ask you about indications for total elbow arthroplasty. You remember, you must have a sufficient triceps. If your triceps is non-functioning, then this is contraindicated. In terms of the complications, you worry about ulnar nerve injury. And they may show you a case where you have a fracture with a total elbow. And essentially, if it's minimally displaced or the implant is stable, you want to treat these non-operatively. But if it's displaced or loose, that's when you revise them. So just time for a couple of questions. Intra-articular fractures of the distal radius have what percentage of associated intercarpal soft tissue injuries? So remember, here we talked about TFCC is the most common. Ligament injury is scapholunate. And so the answer here is 68%. Most of these are treated non-operatively. A 22-year-old male presents for a second opinion with wrist pain after undergoing surgery 6 months ago. So you can see here he has a scaphoid non-union, probably not well aligned on the lateral radiograph. If you look at that position of the screw, it's too horizontal. So what's the treatment? Do you immobilize in a cast? Well, that's not going to heal. A bone stimulator, that gap's too big. Wrist denervation and scaphoid excision, four-corner fusion, essentially if there's arthritis, this is a young patient, no evidence of arthritis. So essentially you're going to revise this fixation with possible bone graft. So the answer here is E. In a dorsal PIP fracture dislocation, what is a minimal percentage area of articular involvement which would lead to instability? So we talked about this earlier. So when it involves more than 40%, this is when you get instability, and that's when you need to fix these, for example, with open reduction internal fixation or a hemi-hamate. Degenerative changes in a patient
with untreated scapholunate dissociation will occur at which joint? So it starts from radial and migrates ulnar. And the key thing is to remember, in most patients, the radiolunate joint is spared. So it starts at the radioscaphoid joint and then involves the midcarpal joint. And so the answer here is radioscaphoid. Epithelioid sarcoma metastasizes via which of the following via routes? The answer here is lymphatics. This is mnemonic for lymphatic spread. Thank you for the privilege of your time.